Hello everyone, my name is Hafsa Aziwidiani Tias, and in this video I will talk about the resume of the second week lecture, Cleft, and Palate. We got three topics from this week. First is presurgical nasoalveolar molding. In neonates, the blood levels of material estrogens are high during the first day of life, giving neonate tissue elastic properties at the time of delivery. The elasticity of tissue is due to increased blood levels of hyaluronic acid, which cause intercellular material to remain disconnected. It appears that to permanently remodel the nasal cartilage and avoid relapse after intervention, treatment should be instituted during this early period. Timing is important when we do the nasoalveolar molding. Nasoalveolar molding consists of an intraoral molding plate with nasal stamps to mold the alveolar ridge and nasal cartilage. The most important aspect of nasoalveolar molding is to eliminating surgical columellar reconstruction and the resultant scar tissue in bilateral cleft and palate. There is an active and passive force. By applying active force, alveolar processes are directed to grow or to be moved into prepline position. Passive appliance works on the principle of negative sculpting. The alteration in the shape of the feed surface of the appliance allows the alveolar process to grow passively as planned by the clinician. And if we don't have an aligner technology, we can use the impression materials. For the cleft children, the recommended material is rubber-based impression material because it's easy to manipulate, good tear strength, setting time can be changed by altering base and catalyst and best result with least flow can be obtained by addition silicones. You have to customize the impression trays. When you select the tray, you should to make sure that the tray is large enough transversely to include the lateral maxillary segment, posteriorly cover the maxillary tuberosities, should help in providing a good reproduction of the mucobuccal folds. There is maybe some complication in impression making, such as difficulty in withdrawal of the impression, respiratory obstruction, foreign body aspiration, cyanosis, difficulty with feeding tubes. And next, we go to the second topic, is nasoalveolar molding for unilateral and bilateral cleft and palate. Nasoalveolar molding is a technique of pre-surgically molding the alveolus, lip, and nose in infants born with cleft and palate. Repair the deformities encountered with unilateral and bilateral cleft and palate to obtain optimal aesthetic can be challenged. Some psychosocial problems associated with cleft are emotional turmoil in the neonatal period, the effect of cleft on the appearance, speech, hearing, poor self-esteem, and unfavorable social response. And in this topic, we can take a conclusion. First is interaction and consultation between various specialties, enhance understanding of the possibilities and limitations of the disciplines involved. Next is the pre-surgical reduction in hard and soft tissue cleft deformity reduce the magnitude of the surgical challenge. And last is in combination with appropriate surgical technique and post-operative management of the scar and reconstructed nose, nasoalveolar molding can improve the aesthetic outcome of unilateral and bilateral cleft lip and palate repair. And then in the last topic of this week is cleft rhinoplasty. In this video, it's going to discuss the technique of semi-open rhinoplasty for primary repair of the unilateral cleft to improve symmetry and outcome. Repair of the unilateral cleft lip nasal deformity is integral to achieving an aesthetically pleasing cleft lip repair. Primary cleft rhinoplasty has been accepted worldwide before the advent of nasoalveolar molding. Deficiency in some or all the components skeletal base, mucosal lining, cartilaginous framework, and overlying skin. And in this topic, we can take a conclusion. First is correction of the unilateral cleft. Nasal deformity remains a challenging task for cleft surgeons. Next is various surgical techniques have been used, most commonly closed rhinoplasty in our subregion. The alar cartilage provides the key to the cleft lip nasal problems. The semi-open rhinoplasty technique, which allows visualized cartilage sections, enable reposition and fixation, has shown to achieve improved aesthetic outcomes. Next is reducing the psychological burden of the stigmata of the typical cleft nose. And last is the Tajima incision is effective in improving nostril hair and alar web. That is all for me. Thank you so much for your attention. I would like to apologize if there is a mistake. See you.